Thank you, Dr. Ashari, for this kind introduction. It's honored to be presenting after Prof. Samsu. Can I just check, can you see my slides?
Yes, Mr. Han, I can see your slide.
Okay, great. A very good morning to everybody that's attending this symposium. I'm Tiong Han. I'll be talking to the crowd about determining immune status of COVID-19 vaccine using some of the immune products and what we can do to ascertain whether vaccines are effective against eliciting their intended use. So the contents of my presentation will include a little information about the human immune system, followed by the diagnostic solutions at EUROIMMUN, and as well as some alternative pathway that people can actually look at to evaluate the immune status. So a short introduction of the human immune system. When someone is vaccinated or exposed to the SARS coronavirus, what happens in the body is that the innate immune response to the virus starts to get activated. Through that, a series of induction of adaptive immunity starts happening, whereby cytokines are produced, and there's a regulation of inflammatory process as well as some other cells to help kill these infected cells or virus away. What we know from literature or with this information of vaccination is that everybody is looking at plasma or antibodies, which is what we know as commonly known as the humoral antibody response. However, downstream, and as said by Prof. Samsu just now, there's also something called a T cell or cell-mediated immune response, which is commonly known as the T cell, which is linked to the T cells. So together with the cell-mediated response and the T cells, it shows how the body combines the T cells as well as antibody response to fight against infection or prevent somebody from getting more severe disease downstream. At EUROIMMUN, we have more than just ELISAs of detecting antibody response after vaccination or post-exposure to the viruses. But we have a complete array or solution of products, which includes antigen detection, molecular tests to detect the virus load, so on and so forth. Okay, so let me just first introduce to everybody what we should do when after vaccination or even post-exposure to the virus, what kind of product people can use to understand whether antibodies level are present in the patient. At EUROIMMUN, we do have a product called the ANTI-SARS-CoV-2 QuantiVac ELISA. This measures total binding IgG antibodies. The QuantiVac ELISA provides a calibration curve with our calibrators, and this provides quantification in reference unit per mil or in the standardized binding antigen unit, antibody units per mil from WHO. This product is to determine the anti-S1 IgG antibody concentration in the patient itself. Our product has shown excellent correlation with the WHO's first international standards, and it does have good agreement results in comparison with other neutralization assays. This product can help you aid the assessment of humoral immune response in the context of infection, vaccination, or even in some cases where people are looking at convalescence plasma treatment, or what we know as antibody therapy. Our product is fully automatable, and it does have high sensitivity and specificity towards the SARS-CoV-2 virus. As you can see on the chart in the bottom, this is our correlation data done with the WHO calibration or controls that what is known as the NIBSC controls that's issued by WHO. We do have a very linear curve that is seen with a high R value of almost 1. which shows that our calibration curve and the results that is being produced by this product actually does have very high correlation and is very accurate in terms of the standard that's issued by WHO. Some other assays that we have done to correlate our QuantiVac ELISA includes correlating it to our other neutralization assays. So using commercial surrogate neutralization assay, we have seen that there's a high agreement value of about 98.2%. And at the same time, if you are to compare it with the PRNT50 assay, which is the gold standard assay for measuring virus neutralization, we have seen a high agreement value of 97.3% for our QuantiVac ELISAs, which shows that not only can we replicate or show something similar of the gold standard assay, but at the same time, our QuantiVac assay does produce high quality results. The next thing I would like to share about would be the concept of neutralizing antibodies and plaque reducing assays. As we know, neutralizing antibodies are antibodies that plays a part in the immune defense of SARS-CoV-2 in the event of SARS-CoV-2 infection. How neutralizing antibody works is that essentially it blocks the virus attachment process, thus preventing the virus from entering the cell. So downstream wise, the virus is not able to replicate itself, and this will, in terms, reduce the amount of viral load in the near future. However, one thing to know is that the neutralizing antibodies is just a small subset of the total binding antibodies out there. And antibodies do not just play a neutralizing role, but it does have other immune stimulating factors downstream. Another concept that I would like to introduce to everyone would be the plaque reducing neutralization test, or PRNT test. I've mentioned the PRNT test is a gold standard for detecting and measuring neutralizing antibodies. However, the downside of the PRNT50 test is that a large amount, or rather live virus, has to be cultivated, and with the biosecurity of SARS-CoV-2, a high containment lab or a BSL-3 facility is a requirement for culturing this virus. Another thing to know about PRNT tests is how do they measure it is by looking at cell cytopathic effect after infection. So because the cells need time to reproduce and the virus need time to replicate and the cells need time to react to this, a longer turnaround time is often associated with PRNT50 tests. As you can see, I've shown a diagram on the bottom right. Cells are actually, first, the cells are needs to be seated onto a 96 well plate or 384 well plate, depending on the platform. And this requires overnight incubation so that the cells can actually be plated and coated onto the bottom of the plate. Then on the next day, the virus and neutralizing antibody from in the serum will be mixed, and this will be incubated with the cell. And it requires an additional 16 hours post-infection to be able to see any form of CPE or effect from the cells and this neutralizing antibody. Hence, the total turnaround time for this is not less than almost 2 days. And it also requires a high amount of skilled laboratory technician, as execution of and precision of cell seeding and a measuring of cells to culture the cells and viruses is a delicate process, and it may be prone to contamination. So high skilled technician is required for this process as well. So here I would like to introduce to everybody about on our anti-SARS-CoV-2 NeutraLISA, or what we know as the NeutraLISA for short. The NeutraLISA is a micro-titer plate-based inhibition assay. It helps with the early detection of antibodies that actually inhibit the S1 RBD domain as well as the ACE2 receptor binding domain. We have seen a lot of very high agreement of results in comparison with the PRNT50 test, which is the gold standard test I've mentioned before. The pro of this test is that no virus stock or BSL-3 condition is required to conduct this test, hence reducing the amount of cost for the laboratory to run this test. If it is very similar to an ELISA format, which many laboratories are very used to, hence a standard laboratory procedure can be applied to this assay. At the same time, with most Euroimmune products, automation processing is always possible, and this will allow high throughput for testing of patient samples. The results using this NeutraLISA test is achievable within 2 hours, and thus comparing it with the PRNT50 test, this allows a faster turnaround time. It's also cheap as what I mentioned, is cheap as compared to the conventional PRNT50 test, and it does show high sensitivity as well as specificity for our neutralization test. I've mentioned that neutralizing antibodies is a group of functional antibodies. In a way, how we deem whether it's functional is that it must be able to show some form of competitive inhibition against the ACE2 receptor. Unlike other assays out there whereby they just says that the test antibodies that binds to RBD domain. However, we know that there might be cases whereby antibodies which bind to the RBD domain may allow the binding of the virus to the ACE2 receptor on the cell. Thus, this doesn't actually neutralize the process, but just as the virus can still enter the cell. However, using our SARS-CoV-2 NeutraLISA assay, what we have seen is that what we show is that we do provide a competitive binding between the ACE2 as well as the neutralizing antibody in the well itself. So in the presence of neutralizing antibodies, we are able to tell you whether the antibodies in the patient's serum itself is a functional neutralizing antibody or the patients do not possess such neutralizing antibodies. A simple workflow schematic is shown here about our NeutraLISA antibody. What we've seen is that patient serum is diluted with our sample, and only 100 microliters of diluted samples is then needed for this assay. A 60 minutes incubation time at 37 degrees is conducted such that we can check whether the patients do have functional neutralizing antibodies in their serum or not. Next, this is washed, and a secondary step of incubation is then conducted whereby only 30 minutes at room temperature is needed for this reaction. Lastly, we just go through a simple chromosome substrate solution whereby colorimetric detection is shown whether the patients do have this functional neutralizing antibodies in their serum. And all this is measured using automation that's available either as an open source reader or with Euroimmune's automation suites available. So what the SARS-CoV-2 NeutraLISA antibody actually does is that it measures all immunoglobulin class. However, we know that most people might be vaccinated now, so we say that it measures mainly the IgG class, which is the large percentage in most serum. However, we do know that we do acknowledge that there are cases whereby immunoglobulin neutralizing antibody of immunoglobulin class such as IgM can also result in the results in showing that the patients do have neutralizing antibodies in their serum. The calibration of this NeutraLISA assay measures the OD of blanks, whereby it's just ACE2 buffer, or ACE2 that gives the results. And if let's say the patient do have neutralizing antibodies in their serum, we reflect our results in terms of percentage of inhibition, whereby we show that there's in the event of decreased signaling from the patient's well, we know that there's inhibition of ACE2 binding, which represents that the patient do have neutralizing antibodies that is present in the serum. Using our kit, a positive control as well as a negative control is already included. Hence, the laboratory do not need to purchase these additional controls, which increases their cost of running the test. The schematic of how inhibition will look like is presented on the right. In the presence of functional neutralizing antibodies, you will bind to the coated antigens that is on the plate, ELISA plate itself. With this inhibition, there will be no signal that is shown through this process. However, in a case whereby patients do not have neutralizing antibodies, ACE2 that's conjugated to give signal will bind to the antigen that is coated on the plate. And through this process, a chromogen, or rather a signal, will be given such that to show that the patients do not have this neutralizing antibody, because the ACE2 is able to give out this signal downstream. Our neutralization assay versus the gold standard PRNT assay in a laboratory setting has shown that there's 100% agreement. Thus, it is secure to say that using our PRNT assay or NeutraLISA assay, you do have very high agreement, and the results from our NeutraLISA assay actually correlates very well with the PRNT 50 assay, which gives the laboratory and the people reading the results a peace of mind, such that they know that the results is of high quality and is usable. As we compare our NeutraLISA antibody assay with our QuantiVac assay, we have shown that using high in an event whereby the patients do have high amount of total binding antibodies available, the neutralizing antibody levels will also be present. This is seen with our internal correlation studies, whereby with patients with up to 200 or more BAU per mil total binding antibody, we do see a high correlation of neutralizing antibodies within their serum, and this correlation data has shown an R-square value of 0.97. Thus, we do know that people with high amount of binding antibodies is also expected to see presence of neutralizing antibodies within the serum too. Okay, I've talked about antibody assays for the good past 10 minutes, but I would like to just highlight something here. Antibody testing is a method of choice. However, we do know that some patients with medical condition actually do not develop this detectable antibody response. From Prof. Samsu's slides, we also heard that antibody may wane over time. For SARS-CoV-2, the correlation of immune status is still unclear, as nobody has provided an official guideline or immunity cutoff. So what can we do for people who actually do not have antibody levels or develop detectable antibody levels in their body? What can we actually provide to ensure that vaccination actually helps them in a way? So at EUROImmune, what we have is that we know that we have seen that patients with reports of cellular immunity actually shows that patients either on solid organ transplant or immunosuppressant therapy actually have shown that they do have cellular immunity that actually provides them some form of protection in their cell-mediated immune arm after vaccination, or either the mRNA vaccine or using the vector-based COVID-19 vaccine. So at YEO Immune, we have this product which has recently been launched and CE marked, called the SARS-CoV-2 quanti-cell assay. What this assay does is that it measures the interferon gamma release quantitatively to determine the amount of interferon that's being released from this SARS-CoV-2 specific T cell. A simple workflow includes withdrawal of heparinized lithium heparinized blood from the patient that we would like to test, and these are incubated over into specific tubes. This, in the presence of, if let's say the patient was previously vaccinated or exposed to SARS-CoV-2, activated T cells within the patient whole blood will actually generate interferon gamma. This interferon gamma is then subsequently tested onto our quanti-cell ELISA, which will give you a quantitative value downstream to tell you whether the patient was previously exposed to SARS-CoV-2 or whether their T cell actually memorized or have seen peptides that resemble this SARS-CoV-2 spike protein. Thus, this is a good way to actually tell people who do not have detectable antibody level. This is an alternative testing methodology that we can tell them whether, you have been vaccinated, but although you do not have detectable antibody levels, your cellular immunity arm actually does work as is being seen and laboratory tested using this test and technology. So in summary, what I'd like to just conclude is that the development of antibodies happens after the exposure to virus or either post-vaccination. Hence, we do not need to worry whether using our products is a good way to check whether the patients whether they do have antibodies that's developed either through post-exposure or vaccination of SARS-CoV-2. However, one point I would like to reiterate is that the total binding antibody and neutralizing antibodies can indicate the functional immunity against the pathogen. This is done through total binding antibodies can activate cellular mechanisms to remove virus, or in the case of neutralizing antibodies, it actually helps prevents the attachment onto the virus cell itself. In the event whereby no antibody is tested, we also recommend that to look at the cellular immunity arm of the patient, where this using cellular immunity can actually help to provide clues whether immunity does the patient do have immunity against this SARS-CoV-2 virus at all. So with that, I would like to thank everybody for your time on this early morning on Saturday, and terima kasih to everybody. Thank you.